gallery view for the moment.
And we are live on Facebook.
Welcome everyone to the COVID-19 communityresources.com town hall meeting powered by the Center for Closing the Health Gap. Your moderators today will be superstar Tropikana from The Wiz, and I'm Councilmember Jan-Michele Kearney. We're going to tackle a really tough topic today, but a very important conversation. We're going to talk about maternal mortality during COVID and how can you increase your chances of a safe and healthy pregnancy during this pandemic. So we've got three expert panelists and we're going to introduce them to you in just a second. First, of course, let me thank our tech team. We've got John Reichel and Lauren Harden. And I'd like to remind you that we are taping this session so that we can repost it for those who can't be here at this moment. So if you're on Zoom or Facebook, feel free to go right ahead and start entering your questions. Let me start by turning the mic over to superstar Tropikana to bring in our panelists.
Hello, Jan-Michele and Kearney. So wonderful to see you again and join you on this panel today. Today we have Dr. Michael Thomas, Director of the OBGYN Department at UC. Dr. Thomas, would you like to say some starting or opening word?
Yes, she said my name is Michael Thomas. I've been in Cincinnati for a long time, and the first Black African-American chair at the University of Cincinnati, which means I direct the OBGYN department. Even though my day job primarily also consists of helping people get pregnant, but maternal health and the effect of COVID on women is one of the things that I'm very, very interested in. Thank you very much.
All right, thank you, Dr. Thomas. We have Dr. Roosevelt Walker, immediate and past president of the Cincinnati Medical Association.
Good afternoon, Tropikana, and thank you for hosting our program. I've been in Cincinnati for 36 years practicing obstetrics and gynecology, and I am no longer in private practice now, but I work now as the Associate Program Director for the OB-GYN Residency Training Program at Tri-Health. And I am teaching residents and medical students now at Good Samaritan Hospital and at Bethesda North Hospital. And one of the big issues that we are tackling now is the death rate for African American women during pregnancy. So thank you for giving us an opportunity to discuss this very important and timely issue.
I'm looking forward to learning more. Dr. Lane, I'm not even going to try to butcher your name because I knew I was going to. So if you would love to say it for me, I would love to practice saying it after you. Dr. Lane.
Yes, my name is Anthereca Lane, and I am currently in private practice. I am the owner and physician at Lane Women's Health in the Finneytown area off of Winton and North Bend. So it has been such a pleasure serving the community of Cincinnati and working along with these two esteemed colleagues with the Cincinnati Medical Association.
Thank you so much for joining us, Dr. Lane. I'm sure we're going to learn a lot today from all three of you. It's your turn to ask questions. If you're on Zoom or Facebook, you may enter your questions or your comments. We'd love to know your name, but it's okay too if you have private questions that you don't want anyone to know that you want to ask. Let's turn it over to Jan-Michele Kearney for our first questions.
Thanks, Tropikana. And I should have said this at the beginning, but the idea for this panel came from Dr. Lane. So Dr. Lane, we just want to thank you. This is really important information. I wanted to start by just setting the stage for where we are in terms of Black women's health, in terms of pregnant women. Are we ahead or behind? How are we doing? And also, how does COVID affect all of that? And Dr. Walker, I know you had some information about mortality. So let's talk about maternal mortality.
So we're gonna set the stage for the conversation with a couple of very important facts. Number one, for African American women, the rate for a death during pregnancy is 3 to 4 times the rate for women who are white. And statistically, for every 100,000 women who, 100,000 African American women who get pregnant, 44 of those women will die. That number for white women is 17 per 100,000. That number for Hispanic Latina women is 12 per 100,000. So African American women have the highest death rate related to pregnancy of any demographic group in the country. And another astounding fact is that even when we correct for age, education, job, income, in the neighborhood in which you live, African American women are still number one. An African American woman with a college degree still has a higher death rate during pregnancy than a white woman who did not graduate from high school. Think about it.
Yeah, that's a lot to take in, and of course the big question is why. So we're going to address the why and what we can do about it. But let me jump to Dr. Thomas to throw in COVID. Now we've got COVID in the mix. How are we doing with pregnant women and COVID?
Well, thank you, Jan-Michele. You know, the data, I have this fresh from our American Association for Reproductive Medicine. We have a COVID task force, and they try to update us every week. And the numbers that came out yesterday, that as of July 16th, the 7-day average was increased by 70% for just COVID in general. But when we start looking at the number of people, because this has become sort of a pandemic now of the unvaccinated. 97 to 99% of the people who are getting sick from COVID, I'm talking about hospitalizations and deaths, are primarily the people who are unvaccinated. And it appears that in pregnant women, the pregnant women who've had one or more injections of any of the vaccines is now only 16.3%. So that leaves a large number of people at risk. And we've had deaths. We had a death not too long ago at the University of Cincinnati of a young lady who was not vaccinated, who passed away, but we were able to save her baby. But now her mom and that family are now raising this child because this patient died from COVID.
Oh my goodness. Okay, so and when you say 16.3% of pregnant women, do you mean all pregnant women or Black pregnant women?
All pregnant women. So the number is probably lower in African American women.
Okay, all right. Okay, so let's kind of back up a little bit, and Dr. Lane, I'm going to ask you to just give us, some basic education on, what are we talking about when we talk about maternal mortality? Dr. Lane, you're muted.
When we talk about maternal mortality, we're really talking about the first 42 days after delivery. And this is such a critical time. And for many organizations, this time is now called the 4th trimester. And the 4th trimester traditionally had been a time when babies delivered, OBGYNs can finally take a breath. We got the baby out safely, mom's doing fine, and we'll see mom in 6 weeks. That used to be kind of the traditional plan. But now we're realizing that we need to walk alongside our women, all women really, and particularly African-American women through their 4th trimester. It's during this trimester that you begin to see some of the problems, such as hypertensive disorders, such as heart-related conditions that can arise after delivery.
Wow.
Why is this such a topic we have not discussed before?
And I'm sorry, I missed that question.
Why has this gone undiscussed for so long? Why haven't we talked about the 4th trimester or this after birth time period, or why hasn't that been discussed?
I think that's really a good question. I think some of it comes down to it being a systematic and a structural problem that needs to be addressed, even from the very basics of collecting data. If you're not searching for the problem, if you're not asking the questions, then you can't then be enlightened by the information. So for example, if you have hospital A, hospital B, and hospital C, and hospital A, B, and C, none of them are collecting data on racial and ethnic disparities, then how will they know that there is this disparity that occurs? So that's just one little nugget as to why we haven't been discussing it. But I think when you look at certain, whether it's celebrities or not even just celebrities, there have been really high level educated women who have died as a result of conditions related to pregnancy. And when you look at that, you have to begin to pay attention and realize this is more than just a simple question of, oh, it's low income, it's lack of access to care. We have examples of educated women who have sought out care and then have their doctors or providers or midwives or nurse practitioners, have they really recognize the significance of their symptoms as well? It's just so complex.
Yeah, I think that Dr. Lane brings up something very, very important. It's who you see, where you go, and who can recognize the problems that you're coming in with. People who are having issues related to, whether it's blood clots that are usually start out in the calf or in the thigh, and that travel up to the lungs postpartum, because that's a higher risk of things that happen postpartum, or DVTs, or deep vein thromboses. We're very lucky in this community to have 3 level 3 or higher nurseries in the area. And because of that, we have very high risk doctors in tow. University of Cincinnati is the only one with a level 4 nursery and level 4 obstetrical team. But the level 3 and level 4 teams are the place you want to go, which is UC, St. E's, and TriHealth. Other people are trying to get this type of high level care. But if you can be associated, if your condition or your doctor is associated with a high risk group, that will help to decrease some of the chances of maternal mortality, because you're working with people who can recognize these problems early. But the problem always comes into the fact that sometimes what one woman may complain about would potentially be recognized, but if an African American or Hispanic woman may complain about the same thing, it may not be recognized as a problem. And that's one of the issues that we have to get to with training our physicians to be better doctors and being able to better recognize problems in all women.
So, and this really, just all of it is very concerning. And I'm still confused as to why our rates are so high. I mean, you've taken out, education and access to care, all the things that we would think would affect, Black women's mortality. Is it just the healthcare people we go to? I mean, what is going on there?
So in response to that question, one of the most important findings that we have realized now is factors that we define as the social determinants of care. And together, they really have the biggest impact on the quality of care that patients receive, especially African American patients, and ultimately the outcome of their care. And the social determinants of care are basically where we live, work, and play. And it depends on the income that you have, the neighborhood where you live, and that determines your access to healthcare. And also one of the factors is having a healthcare provider who looks like you and understands your lived experiences of life. And that's one of the things that we're looking at, is working as hard as we can to increase the number of African-American physicians or providers of healthcare for African-American patients. In the city of Cincinnati, only 2.1% of the physicians in Cincinnati are African-American. And that's the latest data that we have. And this is a city where 40 to 43% of the residents are African-American. So we also know that the number across the country, African-Americans only make up 5 to 6% of the total number of physicians who are actively practicing now. And we need to increase the number of African-American medical students and the African-American residents that are training, and ultimately the number of African-American physicians who are practicing. And then the other fact that is now undeniable, and which the health world has finally recognized, is that racism plays a very important fact. And we know that implicit bias, cultural sensitivity, and cultural competence also factor into the quality of healthcare that African-American and other underrepresented minority patients are receiving, and ultimately the outcome from healthcare. So we're looking at all those factors now and working to mitigate those and improve the outcome for African-American and other underrepresented minority patients.
And I have to concur with my colleague, Dr. Walker and Dr. Lane. And that's why it's great to have a great organization like Cincinnati Medical Association. Number of studies. If you see a provider that looks like you, you're more likely to get care that would be considered higher level care and more focused care. And I think that the fact that we don't have enough African-American physicians in general is hurting us a lot. And the fact that there are very few, if any, African-American men going into the profession. And I know that a number of physicians in town, led by a number of our male physicians who are looking at this whole area with the Black Men in Medicine program. Dr. Alvin Crawford is really leading that charge.
Well, you know, so let me just say this. So if we're pregnant women, we're going to see our physicians. And so maybe the idea is to have more knowledge about, symptoms of things we want them to see and look at. So can you give us some idea about that? I mean, I think I'd rather know, what I'm looking for. What are some symptoms I should, that a pregnant woman should look for as to something's going wrong?
So I think after delivery or even right before delivery, one of the symptoms you want to think about is, are you having a persistent headache that just does not go away? Whenever I have a patient that has a headache that does not go away, depending on their gestational age, if they're over 20 weeks, I'm definitely thinking about what is her blood pressure. And after delivery, you want to think about the calf pain that Dr. Thomas talked about. You want to think about, are you having chest pain? Are you having shortness of breath? Other signs that go along with a condition called preeclampsia, and along with headache, might be upper abdominal pain. Pain that's not related to the baby's movement. It's just right at the top of the abdomen, or even vision changes. Suddenly your vision is blurry and you have a headache. These are symptoms that you should not blow off. You should definitely call your doctor. And if for some reason you're getting a feeling that your doctor is blowing them off, then you need to come to the hospital and seek care anyway.
I think we get to a very big concern and point that you have to be proactive with your care. You can't just think that the doctor knows everything, but you have to let them know how important and how unusual these types of symptoms are having. And that's why you always want to have a physician provider, whether it's a physician or a nurse midwife or a nurse practitioner who you have a relationship with, who you trust, because they will know if you're feeling something unusual, they'll know to look into it more, or you have to let them know this is unusual and you have to look into it more.
And that's also the beauty of prenatal care. When you are going for prenatal care, your doctor has a sense of what you normally are doing. Your doctor has a sense of, this is unusual for this patient. She doesn't usually complain of these things. And that should be a flag. And that's the beauty of coming to your prenatal visits and being delivered by the doctor that's been caring for you, because that doctor knows you best, ideally.
So, Doctor, I have to follow up on Dr. Lane and Dr. Thomas's comments, because they led directly to the point that I want to make our patients. It's very important for you to become active in maintaining your health care. And there are things that you can do as a patient that help decrease your chances of having a complication with the pregnancy. Number one, you need to have a regular physician. And as a woman, if you're in your reproductive age, you can either have a primary care physician or you can have an obstetrician gynecologist, someone that you see every year for your annual examination and have the annual testing done that we use to identify any problems, because you want to be as healthy as you can be before you get pregnant. And the other thing is planning the pregnancies. 50% of the pregnancies in this country are unplanned. And an unplanned pregnancy has a higher chance of having a complication than one is planned. Also, as soon as you have a positive pregnancy test or you think you might be pregnant, you need to make an appointment with your OB-GYN provider. And that can either be an obstetrician gynecologist, or if you prefer to be seen by a midwife, you can be seen by a midwife, because we have lots of midwifery practices in the city of Cincinnati now, and they have all been embraced by the health community, and they all work in collaboration with OB-GYNs so that they can provide the highest quality of care for you. It's also extremely important that once you are diagnosed as being pregnant, you keep all of your appointments with your OB provider. You make sure that you get all the testing done, because we test you at certain intervals during the pregnancy, looking for complications and trying to make sure that the pregnancy is developing normally. And if you develop a complication during the pregnancy, you must listen to what your OB provider is telling you. If you need to be on medication, you have to take that medication. If you need to change your behaviors, you need to change your behaviors. And again, you must keep those appointments, because that's how we know if you are progressing well or if a problem is developing. And the best way to prevent a major complication is to identify the signs of that complication early in the pregnancy before it affects the mother or adversely affects the baby. And again, you need to be aware of the risk factors that you have if you become pregnant. If you have diabetes, then your diabetes is going to affect your pregnancy. So you need to have your diabetes well controlled before you get pregnant. If you have high blood pressure, you need to take your blood pressure medication so that your blood pressure remains normal during the pregnancy. If you have asthma, you need to take your medication. If you're smoking, you need to try your best to stop smoking, or at least decrease the number of cigarettes that you smoke while you're pregnant. So all of those things affect the pregnancy. And these are all issues that you as a patient can control and make better.
One of the things I did want to add on to what Dr. Walker's great recommendations is the fact that patient also needs to work with their obstetrician or their midwife or their nurse practitioner in monitoring your diet and your weight. It's very important that you don't overdo it. When you're talking about eating for 2, you're not eating for 20. You know, you want to make absolutely sure that, you know, you're going to gain 20, 25, maybe 30 pounds during a pregnancy. You shouldn't be gaining 50, 70, 100 pounds during a pregnancy. Increasing working with a nutritionist during your pregnancy through your doctor's office, trying to make sure you decrease your risk of things like diabetes or high blood pressure that Dr. Walker was talking about. Is not the time just to go all out. It's the time that you really have to be careful, because what you do throughout those 9 months can affect not only your life, but the baby's life.
I would definitely agree with that. You were taking the thoughts just straight out of my mind in regards to that. But the other concept that I'd like to add is the concept of a preconception counseling visit or a preconception consultation. So if you know that you have diabetes, you know that you have high blood pressure, it's probably a good idea for you to go ahead, make an appointment with your obstetrician and say, hey, I'm thinking about getting pregnant. What do I need to worry about? What do I need to think about? Or maybe your BMI is over 60 already and you're not pregnant yet, but you're thinking about it. Maybe you should have a conversation with your obstetrician and say, okay, if I get pregnant at this weight, what does my pregnancy look like? What if I lose 100 pounds? What does my pregnancy look like? These are all questions that you can prepare, you can start thinking about even before conception.
Now, I want to ask a question if that's okay, and thank you guys for those great tips. Dr. Walker, you mentioned you mentioned midwives. I'd like to kind of go back to that. When we talk about midwives and doulas, that is the new craze for everybody on social media. Everybody wants to have a doula or a midwife. You are not in the it when it's time to have your baby if you don't have one. Can you kind of speak to the difference between what that care looks like from a midwife or a doula or coming to your OBGYN? Is there any difference between the three?
A certified nurse midwife is a registered nurse who has received extra training in managing uncomplicated pregnancies. And all the midwives have to work in collaboration with an obstetrician gynecologist. And they are certified to provide care for uncomplicated pregnancies. And even if they, if your pregnancy starts normal and then you develop a complication, then your care can be transferred to the obstetrician gynecologist who's working with them. But for an uncomplicated normal pregnancy, the certified nurse midwife can provide all of your care for you and do the delivery. Now, a doula is a person who is basically a support person for a woman who is pregnant. And they work with you during the pregnancy, also as somebody that you can talk to and someone who can be an advocate for you during the pregnancy. And then in the hospital, the doula is with you during pregnancy, again, to be a support person for you, to encourage you and help you go through the labor process. And you know, when you stop to think about it, we've been doing that for each other since the beginning, have we not?
That's right. That's right.
So they have a new name for it, but it's a practice that we've been doing within our communities since the beginning. But they can be very, very helpful for women, especially if you're having the first pregnancy, you've never been through labor before. And it's very, very scary the first time that you have a baby. And having someone there to encourage you and to support you is very, very important.
I wanted to add a couple of thoughts to this conversation. One is, if someone chooses a midwife, they should have a conversation with the midwife regarding who the collaborating OBGYN is. So I've had a few patients come into my practice who begin to think about a midwife, but their midwife has not identified who their collaborating OBGYN is. That is a very, very dangerous scenario. It's extremely dangerous. Midwives who do it right have a collaborating OBGYN. That's the one that you want. The other little aspect to add about midwives is their philosophy in care. And in my understanding is that midwives really practice on the foundation of labor is physiologic, it's natural, and they really try to support a natural laboring process. So that's something to just kind of add to the great nuggets of information that Dr. Walker has already added. It's just, and I think many physicians would like to have a natural laboring process through that labor curve, as we said, but there are some patients when certain interventions are needed, such as medications. But ideally, we would like all patients to progress naturally through their labor.
And I will admit too, I am very supportive of the midwife concept. Matter of fact, we're in the process of looking at having midwives in labor and delivery at UC and in our Westchester labor and delivery unit to help with the normal labor, but having a physician there as well, but having midwives as being a large part of that, and having midwives being a large part of our teaching staff so they can help teach our medical students. These midwives come with a lot of knowledge, and also our residents. They come with a lot of knowledge. Some of them have been out there for a long time and know a lot of different things. And I was taught by a nurse practitioner when I did my residency in Detroit. So I think that they bring a lot to the table. But they, as Dr. Lane said, they should, especially those who are in independent practice, should be collaborating with a MD or DO physician.
Yeah, and thank you for bringing that up, because Dr. Lane, when you say it's dangerous for them not to collaborate, that's because it's really, I'm assuming, a team effort, and the midwife might have a different viewpoint or give different instructions than the OB-GYN, which could really create some conflict.
Some of that's correct in some circumstances. In other circumstances, it could be a matter of identifying when it's time to be a little more assertive through the labor process. Other times it could be, this is an emergency, and the only way that this baby is going to get here safely is through surgical intervention, so C-section. And that is typically performed by an MD or a DO. So some of it gets to when is it time to intervene? When you have those labors that are natural and baby just practically falls out, you don't necessarily need a doctor there, but I tell you, if something happens when you need a doctor, you need a doctor. And so you want that doctor to be accessible and the right facility to be accessible to you.
And also you've emphasized, well, all of you have emphasized certified midwife. So it's not just someone who hangs out a shingle and says, I'm going to be a midwife. Here's something I'd like to try. I mean, they've gone through some kind of training, education. I mean, there's a process there, right?
Right.
They've gone through, an official training, which I think is 2 years. And then they have to be board certified before they can practice. And there are midwives who we refer to as my brain has left me and I can't the word, but there are some midwives who are not certified, and we recommend that you not see those midwives because they are not working in collaboration with an obstetrician gynecologist. And the term for those are lay midwives. So a lay midwife is someone who hasn't necessarily received formal training and been certified. And we recommend that you not see a lay midwife. And the other caveat, if you choose to see a midwife, then we encourage that because we want you to be happy with your provider. But understand that everybody is not going to have an uncomplicated labor and delivery. And that's where the obstetricians and the DOs come in. If you have to be delivered by cesarean section, then the obstetrician is the person who would do that. Or if you have to have another type of instrumental delivery, then the obstetrician gynecologist would do that.
Okay.
And usually the midwives that are out there have a great relationship with UC or TriHealth, or Christ Hospital, any of the other Mercy. And I think that they generally do a good job. Like I said, our midwife group works in our office. And I know that the ones at TriHealth and the other places, there's usually a midwife associated with a lot of the larger practices in town.
Okay, great. Look, can we go back to COVID now? Because let's go back to, what you're seeing in your practices in terms of women not being vaccinated. I want to get back to that 16.3%. What's going on here with our pregnant women?
Well, it just has to do a lot with the young people who have a decrease in vaccination rates. In general, when we talk about pregnant women, we're generally talking about women between 15 and 40, and those people are less likely to become vaccinated. And that 16.3% is very, very low. And then you take into account people of color, it's lower than that. And I don't have that exact figure, but it's lower. That 16.9 is everybody. So we still need to get the word out that vaccination is just very, very important. People that are getting sick, hospitalized, dying are the people who are not vaccinated for the most part, 97, 98%. And we just need to let people know that it's just so important that you do so much. And there's this fear of vaccination. The vaccine does not decrease your risk of fertility problems. When you get the vaccine, it gets into the muscle, usually the shoulder or deltoid muscle, then it goes away. And then you just get the benefit of the antibodies. So I think people think it's going to cross the placenta. The vaccine does not cross the placenta. There is no data to show that these vaccines harm a baby. And I think there's just this fear that they're going to have problems with either their fertility in the future, but there's just these websites out there where people are trying to gather and promote fear of the vaccine. And these things are not the case. But as you see, the people that are dying are primarily people in these rural areas where they just have their own beliefs. And some people in our community, a lot of people in our community are just afraid to get the vaccine because they think there may be things we don't know about. We know a lot about vaccine. This vaccine has been studied since the 1980s. It's just this has been the time to bring it out. So they are safe and we know they're safe.
Well,
I would like to
yeah,
point out to your audience that Dr. Michael Thomas was actually one of the people who participated in the trial of the vaccination that was held at UC's College of Medicine. And he's still here.
right, thank you, Dr. Thomas.
It's safe.
However,
It's safe.
you're not pregnant, so I'm thinking.
But it is safe for pregnant women to take the vaccination.
Yeah, it is safe for pregnant women.
It is safe
Absolutely.
for pregnant women.
Well,
Yeah, but the data from that I have is the intramuscular administered vaccine messenger RNA remains in the deltoid muscle cytoplasm for just a few days before it is destroyed. However, the protective antibodies for COVID-19 has been shown to cross the placenta and confer protection to the baby after delivery.
okay, break that down into English, please.
Okay, that means that you get the shot, it's just there for a few days in the muscle, it's not traveling around the body, but the antibodies that you create are protecting you, and they don't cross the placenta, so they can't get to the baby while it's inside the uterus. But when that baby comes out, that baby will get some degree of protection for the baby after delivery.
And
So
Dr.
the antibodies can cross, the vaccine cannot, but the antibodies can cross into the placenta to help protect the baby. And by that time that baby delivers, they will get some of that, they will have some of that protection on board.
That protection too. That's great. Dr. How are you dealing with your patients? Because you've got these pregnant women who don't want to get vaccinated.
Was that question for me?
Yes.
Oh, okay. It's a difficult question. I mean, we definitely discuss it. We talk about it. Ultimately, it is the patient's responsibility. We also talk about if they choose not to get the vaccine, what I want them to do until they do get it, which would definitely continue to mitigate those risks with wearing a mask, and I encourage in social distancing and washing their hands. And even if they choose not to get it, I encourage the rest of their family to get it. So it's just such an important time, but I encourage them definitely to continue to have the conversation. We address it in the office. I was trying to do a little reading about this whole issue of infertility and where this came from with the vaccine. And it's my understanding that there was some misinformation related to a protein that's in the placenta called syncytin. And this protein has a genetic makeup that's very similar to a genetic portion of the genetic makeup that's on the spike of the coronavirus. And so there's a concern that the antibody to the coronavirus would also attack this protein that's in the placenta, but that's not correct. I read a good analogy, and someone said it's kind of like this. Person A has a phone number with the number 7, and person B has the phone number with the number 7. They both have something similar about their phone numbers, but you can't call person A with person B's phone number. So it's the same kind of thing. It's like, even though there's this little piece that's very similar, it's not enough for the antibodies to also attack the placenta. So I think that was just misinformation and misunderstanding. That's why it's important to go beyond Google MD. It's important to go beyond Facebook MD and Instagram MD and actually go to an MD or a professional healthcare provider.
Right. Yeah. I know you've brought us a lot of information that's on the internet from your younger viewers and followers, and some of it has just been really shocking. I'm just like, where is that coming from?
Making it up, or they're reading it from their cousin's page, who are also certified through the Board of Medical Association of Facebook. So that's
not the ones we want to call, right? Those are not the certified people we want to call.
The problem is people do get their information from Dr. Google, and particularly from these weird weird sites. But you have to take everything they say seriously, and take, as a physician, and sit down with them and one by one try to make sure that they understand a little bit better, so that they understand that you'd have the actual evidence-based sources of information, so that you can counteract some of the information that's out there that's negative, misleading, and not true.
I think that's such a valid point. I actually encourage patients to have dialogue with me and to bring up, when they tell me that they've researched something, it really shows that they have an interest in their care. And as Black women during pregnancy, sometimes that could really mean the difference between life and death, because you read something and then you brought it up to a physician who's not accustomed to seeing something, and then it can be addressed. So I continue to encourage patients to research, but don't make all decisions based on their research. How about bring it back to the professional to have a conversation?
Right, and really understand it. I'm sorry, Tropikana, go ahead.
I'm sorry, Jan-Michele. I was just agreeing with Dr. Lane. I'm glad that you said that, because one thing that I remember about being pregnant was that I researched everything. And the one thing that my mother and everybody that was around me said, stop looking on Google, because we've just kind of been taught that you can, one, as Black women, we are superheroes. So whatever you're going through, someone already went through it and they survived. So it's not a big deal. So we have kind of been taught to not ask questions about, should this be a concern? Should this be an issue, or should I come talk to you? So I'm very glad that you made that point of saying, bring your questions to the doctor, because we don't even ask questions to the doctors because we can survive it, or so we've been taught.
That's right.
Yeah.
I've been taught that. You know, just getting back to those horrible numbers that we started with, when you were saying, Dr. Walker, I think you said that Black women have the highest death rate related to pregnancy. Can we get back to that for a minute and just talk about what we can do? You know, can we just go back to that? Because I'm still stuck on that. Why is our death rate so high? You know, I know you talked about we need more trained physicians who look like us, but what else is going on there? That, I mean, that's just really, you said 3 to 4 times as high as white women. Our death rate is 3 to 4 times as high as white women. I mean, so that's huge.
The other issue that we're looking at, of course, is the impact of implicit bias on the quality of care that African-American women are receiving. And we know that the majority of African-American patients are being seen by physicians or healthcare providers who are not Black. And what we are doing is beginning to train the other physicians on what cultural competence and cultural sensitivity mean. And essentially that is having an understanding of different cultures and acknowledging that difference, and then paying attention to the concerns and the complaints of African-American women. And one of the things when Tropikana was talking, I thought about the fact that for so many African-American women, your concerns have been dismissed by a provider who is of the dominant caste. And so we are retraining those providers to think more about the lived experience of the African-American woman and the other underrepresented minority women that come to your office, and realize that you have to acknowledge that, and you have to tailor your treatment to this woman who is not white and who has had a lived experience that is different from the lived experience of women who are members of the dominant caste.
You know, one of the things that we've been trying to do, especially at UC, and I'm sure at all the other health systems, is to try to provide this one class care for everybody. Everybody gets treated the same. No matter what your insurance status is, you're going to come in and we're going to treat you with the highest degree of respect, because that was not always done. And that's how people slip through the cracks. You know, we have this great program by my executive vice chair, Elizabeth Kelly, Cradle Cincinnati, which concentrates on infant mortality issues. So once you deliver, the baby goes home. Cincinnati had one of the highest infant mortality rates, almost higher than some third world countries. And Elizabeth Kelly and the Cradle Cincinnati people, which included Dr. Albert Nelson, they've been able to fight and decrease some of these infant mortality issues. Rick Lofgren, who's our CEO at UC Health, came to me and Candace Snyder, one of our other docs, who's a high-risk doctor, and Dr. Kelly, is that we need a task force on maternal mortality. And we're just starting it because we need to understand more what's going on in this city. We know that infant mortality is area codes. In certain area codes like Avondale, Bond Hill, West End, infant mortality was skyrocketing, out of control. We don't know if it's something in the ground. We don't know if it's lead pipes. We don't know what was going on. but we know that we've been able to decrease a lot of that by sending out information. So now the goal is to figure out why in Cincinnati and why do our Black women have such high maternal mortalities? Is it just implicit bias? Is it just say weight? Is it diet? We don't know. We don't have much of a grasp in our community. We're talking about national, but what's going on in Cincinnati? And that's one of the things this task force is going to start taking care of.
I want to also talk about what we're doing at the Christ Hospital. Our Women's Health Service Line is led by a very energetic, sharp young lady by the name of Dr. Leanne Olszewski, and she has put me in charge of the Maternal Mortality Task Force. And we have begun to launch a program that we have named the Ujima Hypertension Project. And I'll see if I can share just a little bit. I'll change my camera here. Let's see if I can share what just the image. And I just want to show you how we're trying to be very intentional about addressing this issue, particularly in the African American community. And what we're doing, this program has about 3 or 4 different pillars where we're really looking at a multidisciplinary approach, which is why we call it Ujima, meaning collective work and responsibility. We've all heard that term, it takes a village. Well, it's going to take a village to address this issue in regards to maternal mortality. And we've also begun to develop a poster campaign for our hospital, and I'll show you a little bit of that here. And this is a poster that was developed by our Maternal Mortality Task Force. And we have a great team with Dr. Heather Boyd and a certified nurse midwife, Michelle Zamudio. And we have also enlisted the help of family medicine residents. This is definitely a team approach, and we are in the midst of developing an order set that's specific to the ED, so that when our patients hit the ER, the ER doctors will know, hey, this is what you should do. These are the medicines you should order. It's all about preventing delays.
And we're very lucky to be, UC is the level 3 hospital that works with Christ Hospital, and we're very happy, level 4, and we're very happy. They have a great program there, and we're gonna definitely get a great task force program at UC, but I think that having program and starting things like that are very, very important, so we can start getting heads up on this maternal mortality issue and the fact that we have these great UC high-risk docs at Christ helping out with that.
Well, I love the fact that these task forces that you all are heading are looking at the why, like why is maternal mortality so high with Black women, and then what we can do about it, because that's just, this should be a time of joy in everybody's life, having a child, like, what's more special than that? But then to know that, your risk of death is high because you're pregnant, that's just horrible. And then of course you worry about your baby's health as well. So I thank you all for that work. That's fantastic.
Yeah,
that is wonderful.
I wanted to mention there was I'm sorry, go ahead.
No, Dr. Lane, you go right ahead.
There was a model that was developed back in 1994 called the 3 delays model. And I just wanted to just put this out there. Anybody can search it and Google it, by a Dr. Thaddeus in Maine. In 1994, you think, oh my gosh, like how long ago was that? But it's still very relevant. And basically what it proposes that maternal mortality is overwhelmingly due to delays in deciding to seek appropriate medical help for an obstetric emergency, reaching an appropriate facility, and number 3 is receiving adequate care when a facility is reached. Now, this was back in 1994, and it's still relevant today, which is why it's so important for patients to advocate for themselves so that they can get the care that's needed, and for hospital systems, when they encounter the patients, to be able to identify this is an emergency and to be able to really inactivate, just very much like when you say code blue and that team comes running in, there needs to be a code that, hey, we have a Black woman having an OB emergency in this hospital. We all hands on deck.
You know what?
See, now that
The
reminds
nice
me-
thing about these types of talks is that you have these great docs that are UC Health, Tri-Health, Christ Hospital under the Cincinnati Medical Association umbrella, who have this great knowledge and are really trying to do things in the community. And my colleagues here who are great obstetrical providers are doing such a great job in trying to help the community.
Absolutely. But this reminds me of what Tropikana was just saying about the culture of Black women saying, you know, we can push through this. And you say delay in seeking help because, you know, we're thinking, oh, you know, we're fine. We can get, it's just a headache, you know, my leg is hurting. What's the big deal? I'll just get through it. We've got to change the whole culture of how we're thinking.
Right. Somebody. If something feels weird, go talk to your doctor.
Right.
Yes.
What is that?
Don't be afraid to do that. Well, you know, I would like to ask each of you to give us a takeaway. You know, just, you know, what are the most important things we can take away from this conversation today? Because we've covered a lot: maternal mortality, infant mortality, the effect of COVID. What are the most important takeaways for us today?
I guess I'll start. I think the things that I think that the messages that have to get out are the messages that Dr. Lane and Dr. Walker have been talking about, which is the fact that you have to seek help. You have to understand when anything's unusual during your pregnancy or after your pregnancy to seek help with your provider. And if you don't are getting what you need from that provider, get another provider.
Okay, if you don't feel comfortable with that provider, if they aren't
Exactly.
responding, find someone else. Okay, all right, good to know. All right.
I would like to add to that. It's just very important to advocate for yourself. Listen to that inner voice that says something's not right. And then as a message to all of those who are involved in the care of our women, of Black women, be intentional, have a high level of suspicion, be intentional and strategic about how you're going to address this concern. That's the only way we're going to make a difference, if we all come together and recognize that this is an essential issue for us to make a difference.
Okay, great. Dr. Walker?
I want the audience to know, and all of your relatives and friends to know, that Black physicians are here and we want to take care of you. I've been in Cincinnati for 36 years. I still get phone calls from someone asking for a Black physician. We are here. We represent almost every specialty, and all you have to do is look for us. You can go to the Cincinnati Medical Association website. Everybody is listed there. You can call the Center for Closing the Health Gap. They can contact us. We represent every specialty. We're at every hospital system. And if nothing else, you just call the hospital and say, I want a Black doctor who does obstetrics and gynecology. I want a Black physician who does pediatrics. I want a Black physician who does dermatology. We even have 2 Black female plastic surgeons in Cincinnati, okay?
Oh, really? Wow.
We are here and we want to serve you.
And I want to give UC kudos on their number of African Americans that are in primary care. I mean, you have to see that they have truly made an intentional effort to make their medical staff look like the community. So kudos to UC, and hopefully all of the hospital systems in the system can begin to value the presence of African Americans on their medical staff.
That is great. And so here are some takeaways I have today. These are some things you all have taught me. You know, one is women who are thinking about getting pregnant, plan ahead, start seeing your doctor, you know, get your body in shape, get ready for it, right? Another thing is to do some, and I guess that's part of planning ahead, doing some prenatal consultation with your physician, which means you have to have a physician So establish that relationship early. And when you're pregnant, do not be afraid to get vaccinated against COVID. I mean, the fact that we're at 16.3% is outrageous. Women, all races, all backgrounds, if you are pregnant, please get vaccinated. Save yourself, save your child, right?
Exactly.
We got to do that. So, I wanted to give Renee Mahake Harris and Tropicana, you can jump in too, but I wanted to give her a little bit of extra time today because, one of the things that we talked about was how can the Center for Closing the Health Gap help with this disparity, the fact that Black women have a 3 to 4 times as high maternal mortality rate as white women. What can the Center for Closing the Health Gap do in that space, Renee?
Oh, so you're asking me what we could do? Well, I think what we can do is really begin to better understand the preventative steps that you've outlined today, and do maybe a better job, or figure out some ways to actually be a part of building a message that speaks to maternal health specifically, but also speaks to the preventative things that, because many people, it's amazing to me that many people bring up disparity and the first thing they say is about maternal health outcome. So across the sector, not medical professionals, not nurses, not anyone, people know that statistic about maternal health outcomes. So maybe what we can do is potentially either do some focus groups so that we could tease out some of the common misinformation or clarity of information that's needed, and then provide a campaign that talks about here's what we can do to save our lives as it relates to the disproportionate impact of our Black women dying at childbirth. So I'm thinking I'm just thinking that might be one way. And the Black women's health movement, which really looked at a lot of research locally and conducted research locally to reinforce really what Tropicana said, which is that, we may feel something, right? But we're so busy because, in our community, 72% of our households are single women head of household, right? So it's like, well, I can just worry about that later because I have to do something with my kids or family member, what have you. And so I do think that we also need to begin to talk more about how we put ourselves on our list and how we listen to our bodies. And, so Dr. Lane, I think you talked about a number of things that I think we really need to get some kind of message going that people can that they can see themselves in the conversation. I'm obviously talking about from the top of my head some thoughts on how to do that. I know that anything that we do is usually based upon research, and it's usually based upon a participatory research approach, which means we are going to go into the community, ask those questions in more of a qualitative way, but also ask them in a quantitative way so that we can better understand what people know. Because I think some of the things that each of you, and thank you, Dr. Thomas, and thank you, Dr. Lane, and thank you, Dr. Walker, you are also awesome, and we are so blessed and fortunate to have you here. But what we need to make sure we can do a better job of doing, I'll say from the health gap, is making sure that we connect into these conversations. So this is a town hall, but I think we need more. I think for us to make a change in an issue that is having a 4 to 1 time difference in death rates for Black women, this is urgent and crisis. Yes, COVID is a crisis too, but I think we need to elevate this and come up with some strategies with you so that we can bring the information from you to individuals in the community in maybe a more informal way, just as we've done with the vaccine and COVID-19. Perhaps that might be a way. So I'm looking for like a nod of head from Dr. Walker, from Dr. Lane, if that might be a way to go. I don't want today's conversation to begin the beginning and end of this conversation, because we know that this might be the one area of disparities where you can clearly see that is a racial component, a racial construct that creates this difference. We might not know the why, but this might be the place to start as we talk about disparities, as you work in this field and you see the factors that contribute to the disparate outcomes for us. You said a really important piece, which is advocating for yourself. That is probably the primary thing, the primary concept of the health gap. We want to equip you with the tools, the knowledge, so that you can advocate for yourself. That means, as Dr. Thomas said, if your doctor is not making you feel safe or being responsive to your questions, find a new doctor. As Dr. Walker shared, you can call the Health Gap, and we have an updated list of who all the Black physicians are. We can contact them and have them contact you. I think we will have to be more intentional in the strategy specific to maternal health outcomes, though. And so this is something I'd like to take on, and I'm going to reach into Tropikana as well as Jan-Michele Kearney, Councilmember Kearney, and you to have a conversation after this meeting, right? To set a meeting to say, let's figure out a strategy. So I am willing to take on that responsibility of bringing us together to get that conversation going and figure out a strategy together. I know I have a minute left, so I want to say the Delta variant, the Delta variant. The protection against the Delta variant is getting the vaccine. I am not going to tell you to take the vaccine. However, what I'm going to say is, if you still have questions, let us know what those questions are. Let us answer your questions. I think your questions and concerns are real, and we want to make sure you get responses. All of the physicians at Cincinnati Medical Association have been so responsive. Whenever we get questions, we direct them to you, to the Cincinnati Medical Association, and they respond. No matter if it's someone posting something on Facebook, we get that question and someone responds for us so that we can send a response back to that individual. So information is power. We must continue to work to save each other, and the maternal health outcomes in our city, in the state, in this country must be addressed. And we thank Dr. Lane and Dr. Walker and Dr. Thomas for the leadership that you're providing in our community. And we must work together with you to address this very serious issue that is consistently disproportionately impacting Black women. So I thank you all for being here today. Thank you, Tropikana. Thank you, Councilmember Kearney. I hope that you all have a blessed rest of your weekend, and thank you for all that you do.
And just remember, we must save us, right?
That's right. That's right.
All right. Thank you, everybody. Great information today. Thank you so much.
Thank you.
Thank you.